I'll go ahead and get started. So thank you guys for coming to the Hip and Knee IUP webinar series. And we are going to have a webinar presented by Dr. Ballard, as well as sponsored by Zimmer Biomet on advancing total joint care in an ASC. And we'll go ahead and pass it over to Dr. Ballard.
So Jake, does that go to me, or are you gonna pipe in here?
Yeah, I'll do a quick intro. I just want to thank everybody on behalf of Zimmer Biomet for attending the total joint and ASC care session. I'm Jake Silvius. I'm with Zimmer Biomet Medical Education for residents and fellows. At Zimmer Biomet, we have made the commitment to the highest standards of patient safety, quality, and integrity. Part of the integrity lies with not only being able to provide you with great tools and efficiency in the ASC, but with being a trusted partner with you in your ASC journey. Our large ecosystem of services, products provide surgeons and their care teams help in the new challenges they will face in managing their ASC. As you begin your journey as young surgeons in this challenging time of change from the hospital to the ASC, I'm sure you have many questions about what's in store for you. Tonight we have a surgeon with you who has already navigated these waters of change and leads the Center of Excellence ASC in Portland, Oregon, Dr. James Ballard. Dr. Ballard is co-owner in his surgery center and is going to talk with us tonight about the challenges he and his partners face in bringing total joints to the outpatient setting and how Zimmer Biomet Solutions were able to help in this journey. Dr. Ballard, welcome.
Hey, great. Thanks, guys. So I just want to make sure that my computer technology skills, which are obviously limited, are working. So you guys got my screen shared okay? Jake, can you see my,
yeah.
Okay, Sharon gave me a yes,
Perfect.
Awesome. So we got a small group, but this is a really interesting topic for fellows and residents and surgeons that are early in their practice, because you guys are coming out into a world that is much different than the world I came out into in 2003. It doesn't seem like it was that long ago, but when you look at what has changed in orthopedics, particularly in arthroplasty, it might as well be 100 years ago for all the things that have changed. If you had told me when I graduated my residency and finished my fellowship that I would be doing 80% of my primary totals in an outpatient setting with same day discharge, including 80 to 84-year-old Medicare hip and knee replacement patients, I would have told you were crazy, like admitted it, like patently crazy. And yet that's what's happened. And that is the world you're coming out into. I think a lot of you are probably exposed to some of that. Obviously, the move to the outpatient world is happening at different speeds around the country. There's no doubt that it's being accelerated now by Medicare, as you know, Medicare is releasing has released hip and knee replacement from the inpatient only list to where I'm doing most of my Medicare patients in an outpatient setting. It's to the point now where when I tell an insurance company I want to do a joint replacement, and there are times when I have to do them in the hospital, and when I do that, I have to write a paragraph to explain why a 94-year-old female who lives alone has to be done inside the hospital. So that's the world we're in. And I started doing outpatient tools quite a while ago, and this talk is going to be about that journey I took and where I am, and kind of give you an idea of the world you're coming into. It's going to involve how I got involved with Accelero, which is the consulting arm at Zimmer Biomet that helped me make this happen, and talk about the solutions that I have used in that Zimmer Biomet universe to implement in the outpatient setting to make this all happen. I trained a long time ago in Nebraska. I did a fellowship in Las Vegas in arthroplasty, and I've been in practice since 2003. So I've been doing totals now in the outpatient world for 8 years. I'm at about 80-20 now in my mix, which I find a little bit, like I told you, I would have found that crazy years ago, and yet my goal is to go higher than that. And I think we're moving in that direction. And what's interesting is we're doing it in a way that is safer and better for patients than it was in the hospital. So our results for outpatient arthroplasty show lower complications in every metric compared to our hospital patients. And those complication profiles weren't high to begin with, but they are lower in the ASC setting, which is interesting. So why move to a surgery center? Well, for you guys, moving to a surgery center, because that's the world that you're in. I mean, it's expected now. Commercial payers and Medicare, which is the country's largest insurance provider, are demanding it because, you know, the problem we have in the world is we have, and you guys have been exposed to this idea throughout your training, that the demand for arthroplasty is exponentially increasing. We're hitting that part of the curve right now where it's going to, you know, supposed to start going up exponentially between now and 2030, but the amount of money available is going down. So it's too expensive of a procedure that too many people want, and nobody has enough money for it. So we had to figure out, how do we handle this? And when you talk about the cost of a total joint, so if you think about the last total knee you did at the hospitals you train in, I'll use Portland as an average cost example. If you do a commercial insurance, a Blue Cross patient, for example, in Oregon, and if you do their surgery at a hospital, the insurance company is going to pay me $2,600 probably. Anesthesia will get $1,200 or $1,300, and then my hospital will get $40,000. So the bulk of the cost for an outpatient, for a total joint replacement is in the location or the site. And that site fee is where the bulk of the cost is. And then, of course, there's money that is spent on the back end, what we call the post-acute spend. So the movement to a surgery center was inevitable because now you're looking at the ability to do these procedures for 35% less on the site side. So ASCs are paid 30 to 35% less on average, sometimes a bigger number than that, than a hospital. So it is an opportunity for us to do this procedure for less money. And hospitals, for all the good that they do, which is a lot, have just been incapable or unwilling to adjust what they charge because they get a lot. They fund a lot of what they do, at least they have traditionally, through orthopedics, particularly spine and total joints. So since they haven't adjusted, somebody had to adjust, and that's where this move to the outpatient world happened. The forecast, as you go forward, I think this is conservative. The top bar shows you that it's a 7% declining growth in 5 years on the inpatient side, and yet a growth of 27% on the outpatient side. I think that's conservative. And again, you guys are all showing up to the world right when this is happening. Some of you will go into groups where they're embracing it. Some of you will go into groups with older guys like me that want nothing to do with it. And you're going to either jump into this when people are doing it, or you're going to come in and have to be the catalyst for change and have a strong enough voice to start pushing the groups or the places where you work to do this. And even in scenarios where you're employed, your hospital systems are going to eventually, sooner than later, also have to adapt to this and start providing this, and they already are, in their own what's called an HOPD, or a hospital outpatient department, effectively an ASC on hospital property. So again, more volume on the growth of the ambulatory center and you know the ASC environment for cases of all types, not just our center. We do a lot of totals. We do spine, we do cardiology, if you can believe that. We do a ton of trauma. So we get a lot of periarticular fractures that our guys at our trauma center will put spanning X fixes on people, cool their soft tissues down for 10 days, and bring them to our center and do their periarticular work. We have a stack of old X fixes from those level of cases. So this isn't just totals. This is going to be everywhere. These are numbers that when I was a resident, a fellow, I wouldn't have no idea what this meant. This is how much money Medicare gives or will pay an ASC for an outpatient joint. That's $8,700 for a total knee. And just to let you know, that's Latin for not much money. $8,000 does not go a long way if you spend money like hospitals do. However, if you spend money the way, if you look at the Medicare inpatient for total knee, for example, $12,464, That's not much money either. But if you spend the money away, a surgery center can spend money, which is to run very lean, be very careful with what you use. You can make an $8,000 reimbursement work. And of course, we just had hips hit in January. I do a lot of Medicare totals in the ASC setting, and the inpatient only list, which is a list that Medicare gives us that says, look, these cases have to be done in hospitals. And that's where hip and knee replacement were trapped for a long time. And they're getting rid of that list in 3 years. So we're going to start doing revision work in ASCs as well. So a lot of changes happening. So if you're me, and if you can see, I got the gray hair to not quite match this guy, but the idea for existing surgeons that are used to a different paradigm, that are accustomed to, like the way I train, everything was in the hospital. And man, when we got our length of stay down to 3 days, they threw a party for us. So when you start taking people that are in that mindset and getting them to move, you can see kind of the exasperated look on this guy's face, where the people on the right are like, oh, this is really easy. And the surgeon's like, oh, I don't even know where to start. So where do you start and how do you do this? So when you guys get out, you might be lucky to drop into a group or a situation where this is already there. To be honest, the clear majority of places are not there right now. So if you drop into a place where it doesn't exist, you're in luck, because you will have an opportunity to be the catalyst for change that the group or the setting you're in is going to need. Now, when we did our thing here in Portland, we had a group of about 13 surgeons, and none of us, I was the only Zimmer Biomet user. So my hip and knee portfolio choice was a Zimmer Biomet portfolio. One of my partners is a huge Stryker guy. Another one of my partners is a huge Smith & Nephew guy. So when we're going to do this, each of these companies has consulting arms that will help with ASC development. So we interviewed all of them, and we made a unanimous choice agnostically for Accelero, which is the Zimmer Biomet consulting arm. And when they come in, they offer this huge buffet of options, which you're seeing on the screen here on this wheel. There's a lot that has to happen to make outpatient totals happen, even in centers that are already there doing ACLs and rotator cuffs and carpal tunnels and minor trauma like distal radius fractures. So the beauty of this system is when you go into where you're going to be working, or if you're already in practice in a place that maybe has an existing ASC, you don't need the whole buffet, but you need some of it. So Accelero, the Zimmer Biomet ASC solution team comes in and does a kind of a forensic on the situation and can offer, and will only offer, the elements of this that are needed to make this happen. A key thing to tell you is when you get into your groups, or if you're in a group, and they tell you something like, well, we already know how to run an ASC. We've been doing carpal tunnels and ACLs in here for 15 years. We don't need anybody's help. Bringing outpatient total joints and outpatient spine and total joints to the outpatient setting is a different animal, and it has to be treated like a different animal. And you can't just casually drop them into an ASC. It needs and requires planning and foundation setting. And that planning and foundation setting comes through a group like the Zimmer Biomet ASC solution. So when I was in your guys' shoes and I came out, all I had to worry about was on the left. And trust me, when you start figuring out the OR and getting on your own and getting used to everything that goes along with that is a big deal, right? And it consumes you, and it's great because it takes time to learn how to get used to all that. But for me now, my practice is way more than just surgery. I'm a small business owner with my group and with the surgery center. I was in a 3-hour center meeting 2 days ago, talking about all kinds of business decisions and financial statements and all this other stuff. So I have a lot more to deal with now, but I've got a partner in Accelero that has really introduced me to that. And to be honest, made this the best time of my practice. You guys are coming out into training at the single best time to be a total joint surgeon, straight up. We need you. The volume is there. You're going to be busy. There's a lot to do, and the world's changing, and you can be part of that change. So when you come over to an ASC, the surgery is the same. Nothing magically different happens when you do an outpatient total knee or an outpatient total hip. It's the same thing you do when you're in any other environment, like in the hospital. And so you keep that same skill set, but there's a lot of things you have to do to make it work well and to make it work with lower complications and a better patient experience. Predominant in that is standardization. So an excellent example of this is I had an anesthesiologist work with me yesterday at my hospital. He came from another hospital. And I said, hey, what do you guys do at your hospital for total knees? And he said, and this will ring true with most of you. He said, well, all the orthopedic guys at my hospital are all over the map. One wants epidurals, one wants blocks, one doesn't want blocks, one uses a REC periarticular injection, one uses Exparel, one doesn't believe in Exparel. So the idea of being all over the place has been our common paradigm. When you drop into a community, it's very hard to find people that are standardized. But in our place, and this has been proven in the literature to the point where it's accepted fact, standardization in everything, getting a location, if it's a hospital or a surgery center, to have everybody follow the same pathway for everything is absolutely vital. For example, something like choosing who's the right candidate, who are you going to bring? Well, what's the right patient for an outpatient total? That includes obviously figuring out what elements of a medical history would preclude somebody from going there. What kind of surgeries can you do there? Figuring out what people need at home. All of those things are a key thing to get on the same page about. Here's just a random example. 63-year-old male, a BMI of 40, sleep apnea patient, has left knee arthritis, as you can see here. A lot of people look at BMI of 40 and go, oh, 40 and I'm out. We started that way, and we now do people in the, not routinely, but we do people in the high 40s because we've just got a system in place that can handle that. In this case, this guy got a uni and did very well. We're very careful with sleep apnea. Anybody who has sleep apnea or has a stop bang score of a 5 or higher needs to be evaluated with a sleep study and be appropriately treated before they can have an operation. Here's a 64-year-old lady with a BMI of 42, hypertension in her right hip. This is a bread and butter ASC case for us. And there, so there you got a taper lock and a G7 cup, and that person's going to be out of the ASC in 4 hours, and not because we're kicking them out, but because they're ready to go. And again, that happens because of the standardization and the protocols, and getting every doctor on board is vital. And you guys are going to be key. You got to bring a different paradigm to your communities where you insist on standardization and getting everybody converging around evidence-based protocols. And those exist. And Accelero has been involved with centers like mine and several others, including HSS's outpatient program, where you can already key in to these protocols that we've all developed, and you can just use the ones we have, or you can use what we have as a blueprint for what you want to do. And while that standardization is tough, if you guys come in and just insist on it, you can get people from different groups and different fellowships and different training paradigms to come around the same criteria. So my criteria has changed a lot. So initially, I was really picky about who I brought, and I'm getting close to the point now where if they're okay for surgery, I mostly take them to the ASC. Obviously, anybody with uncontrolled comorbidities, CHF, COPD, renal disease, cirrhosis, they're not going to come to a surgery center environment. Diabetics, I bring them all the time, but they got to have their diabetes controlled with an A1C. We're using 8 now as our cutoff. I don't tend to bring anybody with a BMI over 50, but I don't operate on BMIs over 50 anyway. So if their BMI is okay for surgery, it isn't like, well, your BMI is too high for the surgery center, but it's not too high for the hospital. If it's too high, it's too high. So if I'm going to do them in the hospital with a BMI of whatever, 47, I'll still do them in the center that way as well. We don't use ASA criteria specifically like anesthesia does, but certainly anybody with a 3 or higher would be out. I mentioned sleep apnea. Recent MIs or a recent hospitalization within 6 months for a serious medical problem is a no-go. Defibrillators are out. We operate on AFib patients with a history of AFib. We operate on people with histories of DVTs and PEs. We just choose appropriate anticoagulation therapy. Pain management is obviously, it sounds stupid. Pain management is super important. We involved our anesthesiologist early on. So if I could give you guys any words of wisdom, one of them is become friends with your anesthesiologist. Respect those guys and ladies, pick their brains and rely on them and give them the professional respect they deserve, because they know a heck of a lot more about what they do than you do. And getting them involved in how to manage perioperative pain is vital, because they're smart and they can bring things to the table you haven't thought of. So all of these things, about managing pain are more normal now than they were in 2003. I came to life in the middle of the opioid epidemic. My generation was part of creating this whole disaster. So obviously minimizing opioids is a huge deal. Multimodal pain management is key. And if you can believe this, patient education wasn't even really thought of in 2003. We didn't even really do it. It's no wonder people stayed in the hospital and had problems. We didn't educate them. Education is a key element of outpatient joint replacement, including the delivery mechanism, which we'll talk about my mobility in a moment. So the non-opioid, not non-opioid, but opioid minimization is obvious, I think. All of our patients get an oral anti-inflammatory pre-op and oral Tylenol. We used IV Tylenol for a long time. I was a huge proponent of IV Tylenol. Then we studied it, like I am. Keith Barron and Adolph Lombardi in Ohio studied it as well, and several other places have, and we didn't notice a difference. So we're back to oral Tylenol. People get a Decadron dose when they're getting close to the end of their surgery. Obviously, appropriate IV fluids. We use a regional block, adductor canal, and IPAC block for knees. The IPAC block, I've heard appropriately questioned by a couple of studies at AUKUS about a year and a half ago. And I think that's still up in the air, but that's what we use now. Our hips get this is actually transcribed incorrectly. Our hips don't get a regional block. They get a low dose ropivacaine spinal with obviously no narcotic in it. And then everybody gets a pericapsular injection, very similar to that REC injection, the morphine and Marcaine and epinephrine and Toradol and clonidine and some other stuff. We're in the process of cleaning that formula up, but it's a typical pericapsular injection, but every case gets that injection. And when we talk about standardizing protocols, we all 9 of the doctors that do totals give the same narcotic with the same prescription, the same number of tablets for hips and for knees. We give less narcotic for hips because they don't use as much. And we're all going off of shorter prescriptions because that's been shown to decrease overall narcotic use. Everybody gets aspirin 81 BID unless they're aspirin intolerant or if they have a history of DVT or PE. DVT or PE, they get one of the novel anticoagulants. I'm not supposed to say the exact name, but you know what I'm talking about. We don't use Coumadin. Very, very rare if we use Coumadin. But the other ones we typically use, we don't use Lovenox or the injectables at all. Efficiency is a huge deal. You guys have no reason to have to deal with this, but when you're pricing things out and billing things out, there's tons of invoices involved. You get lots of suppliers. Zimmer has offered a way to get a thing called one bill invoicing, where everything for the case goes on one invoice. My surgery center has not been able to do this because you have so many surgeons from different companies. A friend of mine in Mississippi, really great guy named Trevor Pickering, his place runs off of one bill, and I will be forever jealous of that because it offers tremendous efficiencies. Now, something that I never thought about until I opened up an ASC was how many trays do I use to do a total joint? Because when you're in the hospital, nobody cares. It's like, oh, just send it downstairs and clean it. That's why when you open up your pan for a total joint at your hospital, look in that thing and see how many things you don't use. I mean, mine in my hospital had a spoon and a strainer in it, and nobody knew why it was there. It had been there because of some guy like in 1989 or something, but they kept it in there. We had 10 cokers and 7 hemostats and 5 Adson pickups and 7 needle drivers. Well, you don't need all that. So we've got our instrument tray down to about 25 instruments for total hip and about 29 for a total knee for everybody. And then what Zimmer has put together is this thing called efficient care. So the thing on the right is kind of like a tool, a rolling toolbox, and you can take your typical tray volume of 6 trays, for example, for a persona knee and get it down to 2. That's because everything's peel packed. So you size the femur to a size 7. Okay, I need a 7. They open and they peel pack open a 4-in-1 cutting block and a trial for the size 7. I want a poly for a size D tibial tray. They'll peel pack open the poly, so you're not sitting there with a tray. You're doing a little tiny lady who's going to have like a size 5 femur, and yet you got a size 12 femur for the jelly green giant over here. You don't need all that. So with this, you can really reduce that, and that makes the setup of the room faster, which doesn't matter to you guys now, but it'll matter a lot when you do this. Faster setup, faster takedown, a lot less to clean at central sterile and the ASC, which makes it more efficient, which requires less employees, which saves money. So doing this and dialing the trays down saves a ton of money, which is important. This is the Avenir Complete. It's the new edition of the Avenir stem. It's a fabulous stem design. So we're able to get all of this down to a very, very small number and get very efficient with hips as well. Then the ROSA knee system. I could talk to you guys about ROSA for 3 hours. I started using ROSA in October. I've done 84 cases or something with it. And it's 18 years into my practice. I was a robot skeptic, a deep skeptic actually. And it's changed the way I do total knees. I think it's extraordinarily powerful. For me, it's time neutral. So my cases take the same length as they used to, even though I've got a robot involved. It allows, again, optimization of trays because you don't have as much stuff to open, except for the fact the robot's on each side of the table. ROSA knee, again, it requires its own hour of time, but it's surgeon-centered, which means that you run the total knee flow the way you want to do it. If you're being trained on measure resection and you want to do that, then you can set ROSA up to do that. If you want to cut the whole femur first and then the tibia, you can do that. If you do distal femur, then proximal tibia, and then go back to the femur, you can do that. If you're a gap balancer, which I turned into about 5 years ago, and I think is gap balancing with ROSA is the most powerful way to approach a total knee and gives, in my opinion, the optimized outcomes for total knee replacement. ROSA does that in a way that is unique among all other robotic systems currently on the market. It's portable. We have 3 rooms in our ASC, and we can move it easily in between rooms when I'm running 2 rooms at the same time. Now, patient care, of course, is a big deal. I'm telling you, I operated 2 weeks ago at the ASC all week. I never rounded. Now, I know how much you guys love rounding when you're residents. I know you don't love rounding when you're residents and fellows, but when you do outpatient totals, you don't round. Now, the problem is they still need to be taken care of probably at a higher level. Now, and you can do that, but this is where Zimmer Biomet has come in with my mobility to help with that. And I'll get into that in a moment. Physical therapy, of course, is important. Remember, we talked about how much it costs to do a total joint. The post-acute spend, what you spend after the day of surgery, is a big deal. And physical therapy is a runaway spend that we sometimes don't pay any attention to. It's about $90 a visit. And if they're going 3 times a week, I've had patients sometimes go for 3 months I didn't even know. So PT can be a problem because it's hard to get there. It's hard to get a ride. It's a bricks and mortar thing. You have to travel to it. And they're not always obviously available when a patient wants it. So this is where we come to my mobility with Apple Watch. Of all the things that Zimmer has presented for the outpatient environment, if you made me only choose one thing to keep, I would keep this. Because this is an online engagement tool that provides patient education in an on-time manner, meaning, so when we got all excited about patient education, we handed you a big folder. I'm here to tell you, people don't read it and they lose it. And then when it's 3 o'clock in the morning and they're having a problem, they don't go reference the folder to look up swelling or pain problems. They just freak out and make phone calls or go to the ER. So My Mobility, what it allows us to do through push notifications is create an education pathway, which, by the way, Zimmer has an HSS pathway you can just adopt that gives the education to people in the moment they need it. So what do they need to hear the day before surgery? MPO after whatever time, fluids until whatever time. They get that the night before. I know their pain after a total knee is going to be pretty bad on day 2 or 2.5. So guess what? On post-op day 2, they get a message about, hey, I bet you're in a lot of pain. It's normal. And here's how you can handle it. So that goes on and on and on and on for 90 days. And you get to customize the messages if you want, or you can adopt the HSS pathway, which works beautifully as well. What this does is it keeps people educated and they don't have to call the office as much. Now, you guys have been fortunate as residents and fellows, you've got to answer phone calls very much. But when you come out into practice, like some of you are, the phone calls can become overwhelming. And they're not always phone calls that are really deep questions that are, really vital for you, but it could be a patient question that's important to them. And my phone call volume has gone down tremendously because of this, because of the education they get. Now, when they need to contact me, this gives them the ability to text me. So it's a communication pathway that avoids making a phone call to my office. So here is how this works. They get education, they get coordinated communications through text messaging. We can collect prom scores, who's and who's junior scores, Harris hip scores, and it works it right into the whole flow of the communication. The watch keeps track of their activity level, all kinds of biometric data, step count, heart rate, how much they're climbing stairs, how fast they're walking, what their gait stride is like. And it really helps us when we treat people to find out what they're doing. I had a lady come in today who was hurting after a total knee, and she started walking like 12,000 steps a day. And I'm like, look, how much are you walking? Not very much. That's weird because your watch says you're walking 12,000 steps a day. I guarantee that none of you listening to this walked 12,000 steps today unless you went out and walked 5 miles on purpose. So being able to find out how much people are moving and what they're doing just puts all of this together in a beautiful package. So it's education, it's communication, and if you look at that third section, it's physical therapy. So we can deliver virtual physical therapy, which is a modality for PT that's been proven by multiple studies, including a study of our own that we did through the My Mobility program for the last couple of years, where people that get virtual physical therapy, 85% of them do as well or better with virtual PT as they do with actual PT. Now, one other thing to talk about is, so we've got all this intelligent interaction with patients. We have My Mobility, which is we can create and we collect data. We can collect who's and who's junior scores. How well are they doing? We collect pain scores. We know how much they're walking. We can collect that preoperatively, which we do, and collect it postoperatively. So great, we're collecting data. We have ROSA. So with ROSA, we're collecting intraoperative data. How are we correcting your deformity? What exactly did we do doing your surgery? Then we have, of course, the recovery data. Data collection is great, and we all talk about it, but data collection doesn't do much unless you can make it operational. So what Zimmer Biomet has done is created a program called OrthoIntel, which sits above everything and coordinates all this data. So I can look at my patients and see how each patient is doing benchmarked against my other patients. I can benchmark them against all the patients in the My Mobility universe. I can do that based on age, sex, and other issues, a male, female, 60 years old, 40 years old, and see how my people do versus other people in the My Mobility universe. And I'm eventually going to be able, and this is not far away, through artificial intelligence, bring a patient to the OR and register them in the system through their preoperative x-rays, show their deformity to Rosa in the OR, and have Rosa go, look, okay, you're a 50-year-old male with a 10-degree flexion contracture and an 8-degree varus deformity with these comorbidities. Here is the best way we have seen in the 20,000 patient My Mobility universe. Here's how you should fix that person. Leave them in 2 degrees of varus, do the tibia cut, femoral cut, and they can recommend a pathway to executing the surgery based on all of this universe of data that's been collected, which is very, very powerful. So surgical skills and implants, of course, don't change when you come into an ASC. What does change is the work you have to do to make this happen, standardization, efficiencies, and that patient care coordination piece is vital. Because when they leave the ASC the same day, we have to keep track of them. And I'm going to guarantee you, you're not going to have time to do it. You're not going to be able to hire enough people to do it. And this is a way to do it that takes it almost automated, makes it easy for patients, makes them feel better about what's happening, and keeps us in close contact with them without me being on the phone. And so that rounds it out to where we're able to take better care of them and have them feel better about it, even though they're spending the first night of their surgery at home and not in the hospital anymore. So that is the end of the official presentation. So we can go, if we have, Jake, if you want to help us with the Q&A or other things you guys want me to talk about.
Yeah, so we didn't touch on it, but there is a Q&A function at the bottom of your screen next to the chat function. If you want to submit any questions to Dr. Ballard, I know we have a pretty small group, so.
Also verbally submit them as well if you just unmute your microphone.
Yeah, I don't know if you guys can hear me. I got a question.
Yeah.
Chris.
So I'm at Penn right now, finishing my fellowship and joining a private group, and the push is definitely for ASCs. What were the early challenges for you, especially something like urinary retention? Was that something you had to deal with? Is there anything you've done to alter that?
So that's a great question that we worried a lot about early, right? But we moved away from, obviously, epidurals. We didn't put narcotics in the spinals. And while we worried about it and made all these plans for it, we've done 1,600 joints now, and it's virtually never been a problem. So we haven't had, and we're not deeply screening people for BPH. Like if they've got nocturia 3 times a night, we don't kick them out to a urologist. The couple of times they have to void before they leave. The couple of times, maybe 3 times, we had a retention problem, we put a Foley in them and send them home. Then they come to their primary care doctor's office in a day or two, or to our office, and we take it out, and we just haven't run into a problem. But that's kind of our safety net. That we'll just put a Foley in them and send them home. But they have to void beforehand.
Okay, and
before they go home.
Getting spinal or general anesthesia?
So we're doing for hips, and we've gone through every iteration you can think of. So we do low dose ropivacaine spinals, no narcotics for hips, periarticular injections, and of course the multimodal pain protocol. Knees, we do adductor canal and IPAC blocks, no spinal, periarticular injection, and then the same multimodal pain protocols as we do for hips. So Chris, when you go to your group, the beauty is that all of this stuff, if you guys are going to set this up, this program through Accelero, they can just bring you either my protocols, or HSS is going to have some protocols that are going to be kind of standard available blueprints, that you can bring to your center and then tweak them as you want to. So there's no need to reinvent the wheel. And when you do get there to your place, all of us, I'm always available. So if you have any questions, you can reach out to me through whoever your Zimmer rep is.
Yeah, no, I appreciate that. And I think you did a great job explaining kind of what the expectations are for specific deformities and age and gender. And, you get a 70-year-old with a female with a valgus knee. What's done well through kind of the registration of through the ROSA system, which I think navigation and robotics is a huge kind of pioneer for this industry, and it seems like you're on the same page.
I am on the same page. What's funny is I've been around long enough that I've been through multiple iterations of this. Early computer assisted surgery. That's probably when you were in middle school. I don't know how old you were in 2004. But I've been through so many iterations. Where were you? Ninth
I was
grade?
a freshman in high school.
Oh, that's cool. So you're out of middle school. It's all good. It just shows you how old I am. No, so when Rosa came out, well, Mako was the first, right? So I learned how to do unis on a Mako. I thought Mako was great for unis. And then the total application came out. I'm such a huge fan of Persona and how powerful that knee system is compared to either, for example, triathlon, which is tied to Mako. So I held off. And when Rosa came out, I looked into it and kind of slowly got into it. And man, once I really got involved back in October, it's just my favorite way to do a knee. And I'm totally not blowing smoke when I say that. When I got Rosa from Zimmer, I told them, I'm like, look, if I don't like this, I'm going to give it back to you. And I would have fully given it back to him, but there ain't no way I'm giving it back. I'm keeping it. So when, Chris, you bring up a good point. So some people go, oh, this, valgus deformity or this CDH hip or this, whatever. Now, when I first started, I wasn't bringing, first of all, when I first started, I was, 14 years into my practice. It wasn't like I was just out of my fellowship. So my speed of approaching problems improved over time, like everybody's does. You know what I mean? So so I was through that already. So, but even still, I kind of stayed away from serious deformities early on. But I've got such a good system now with what Accelero set me up with that the deformity doesn't matter to me. It's more the patient's situation. Like, if you got a bad valgus deformity, but you're, healthy enough, not perfect, but healthy enough, and you got home help, et cetera, and you're put together well mentally, I'll fix you at the center because I'm not going to do anything different at the hospital.
Yeah.
And when you use Persona, to your point you made earlier, the soft tissue portion of the operation, I think, is not as dramatic as it used to be. And I think it just makes it a bit easier on people. But I mean, to be honest, total knees, I don't care how you do it. Total knees are hard for people to recover from. So they go through pain no matter what you do.
Yeah, I completely agree. And you touched so well on the multimodal pain management. What about for hips? Are you using any sort of navigation?
So I'm not. I have the audacity to be a posterior approach guy. So when I started doing hips, this is back, was like, oh, you can only do a hip if you do in an outpatient setting, if you do an anterior hip. So I like to thumb my nose at the world. So I did my posterior hip, and of course they did absolutely fine. Rosa has a hip application that I have yet to see. The Mako hip application hasn't taken off like the knee part has, because hips are such a different animal to me. I don't think this is hard of an operation. So I don't use any navigation for hips. I've looked into several, but they're so hard to fit everything in the incision. And all they give me is limb length and offset. That's it. Cup position to me is a non-starter because it's so easy to do. I mean, it's just not hard. And the stems can only go in one spot anyway. It isn't like you can take a taper lock and put it in any version you want. So I just haven't had use for that yet. But you can certainly, here's the thing, Chris. When you're in an ASC, here's the beauty. Okay, so when you go into practice and you tell your hospital, hey, I have an idea, they're going to go, who cares? Like, that's really nice, but there's a meeting in 3 years where we'll talk about it. If you have an ASC in your group, you're going to go, hey, I have an idea. And they're going to go, hey, everybody, Chris has an idea. Let's implement it. And then the next week you can implement it because you're in charge.
Sure.
That's to me, that's the best thing about the ASC. When I wanted Rosa, I talked to Zimmer, I got it worked out. I talked to my administrator and it happened. I mean, they delivered it like 4 weeks later and away I went. My hospital, I'm still talking to them about getting a Rosa. And it's been like a year and a half and it still hasn't happened. So the beauty of, outside of everything else we've talked about, is it's going to put you, and you haven't suffered from this yet because you haven't been in practice yet, but being in charge of your own life and making decisions that you can implement is really, really nice. and empowering. It's one of the highlights to me of being involved in an ASC.
Yeah, I mean, I completely agree. And I think that's been a huge kind of influence to where I want to go. One of my biggest concerns is thinking about boards collections and passing part two of the boards. And
Yeah.
I went to the IEP course 2 weeks ago in Austin, and Mike asked and Neil Sheth, everyone's up there saying,
yeah,
don't go to ASC in your first few years of practice because you get hosed, you do something wrong. So, like that you can fail your boards. So what are your thoughts on that?
So I've never been involved in being an examiner on the boards. I've only been on the suffering end of the boards, when I had to go take them or whatever. I agree with Mike. I mean, when you're in your boards collection period, keep it super vanilla in every way possible. But you're in a point now where outpatient totals is defendable. So during your boards collection period, if you do some outpatient totals, you'll be fine because you can defend it. It's not like it's some wacky idea. Now, would I do that? Like I'm doing an 81-year-old tomorrow. Would I do that? If I were you, probably not. I would keep it really within a very conservative envelope. So you can, because when you go to the boards, they're more going to want to find out how you think about stuff. And if you did an outpatient total and you can say, oh, but here's my strict criteria. I don't do these. I don't do these. These were reasonable for the following reasons. Here's the literature that supports it. You'll be golden.
Makes sense. Appreciate it.
Those are great questions, man. I went out. Keith Barron and Adolph Lombardi have an amazing place at White Fence in Ohio and New Albany. And I went out there, and visiting them was the ultimate catalyst that got me going. But I was in the age when nobody was doing it. So it was like, there's a couple of crazy people doing outpatient totals, and I became one of them. So if you want to come in, when you get out there, if you guys want to come visit me, or there's a guy named Trevor Pickering in Mississippi who's fabulous. Adolph and Keith are great. Come visit one of us to kind of get things over the edge. That's very helpful.
Anybody else that's on the line still has any questions?
You can also submit any follow-up questions to me through email, and I'll share them with Dr. Ballard. Thank you guys all for coming. We will have the hip and knee IEP webinar up on our website, as well as the website show up after we all close out of here to be able to get easy access on the 2022 course.
Thanks everybody for your time. Thanks Dr. Ballard, and thank you Zimmer Biomet for putting this on. Appreciate it.